The paper that I am discussing today is about the treatment of highly drug-resistant pulmonary tuberculosis, an article published by the New England Journal of Medicine in 2020. Primarily, this journal talks about the treatment regimen, which is the combined usage of 3 oral drugs for 2 strains of tuberculosis that were found to be resistant to standard treatment protocols. Tuberculosis used to be an international illness that was fatal and had no resolution. However, with the advancement of the medical world, it is now successfully resolved in the majority of the world. Yet in developing countries, this disease remains prevalent and hard to fully purge off. This disease is caused by a bacteria called Mycobacterium tuberculosis, which is a gram-positive bacteria that has mycolic acid serving as external protection. This acid serves to help the bacteria escape immune predation and also makes it less vulnerable to antibodies. As an airborne disease, inhalation of the particles leads to infection of the respiratory system, especially in the alveolar cells, which causes the proliferation and spread of the bacteria. Most of the symptoms that an infected individual would experience are long bloody cough, chest pain, tiredness, fever, and lung cavities. With an international infection rate of over 25%, tuberculosis has taken the lives of 1.4 million people since 2019. The paper examines 2 particular strains of tuberculosis that have exhibited strong resistance towards the normal tuberculosis treatment protocol in South Africa. As WHO had announced that they anticipate the world to be fully eradicated from tuberculosis in 2035, it is important for the journal authors to find a resolution for the 2 resistant strains, which are extensively drug-resistant XDR and multi-drug-resistant tuberculosis MDR. XDR and MDR are defined as being either not responsive to treatment or a second-line regimen is being discontinued due to severe side effects. For both strains, it is noted that there are few treatment options for them currently. In fact, the authors noted that previous experiments for XDR and MDR treatments resulted in success rates as little as 14%. To treat the 2 strains, the authors utilized a therapy combination of 3 oral drugs, bedaquiline, pretomanid, and linezolid, and questioned the success rates of the 3 drugs. At the end of their experiment, they were able to conclude with a 90% success rate and favorable outcome after the implementation of this therapy. The paper included 109 patients that had been retrieved from 3 African hospital sites: the Sizwe Tropical Disease Hospital, the Task Applied Science at Brooklyn Chest Hospital, and the King Dinizulu Hospital Complex. And all of the patients displayed either XDR or MDR strain. The authors used 3 oral drugs to treat these patients. The first drug is bedaquiline, which is a diurequinolin that inhibits mycobacterial ATP synthase and is found to be associated with lower risk of death. The second drug is linezolid, which is an oxazolidinone that is used to inhibit bacterial protein synthesis and is associated with less resistance, as this drug is not commonly used previously. The third drug is pretomanid, which is a nitroimidazooxazine that inhibits the mycolic acid biosynthesis and is also associated with reducing drug resistance. The patients that were enrolled in the experiment were termed as Next TB group, which is a single-group study that involved patients with either XDR or MDR. With an average age of 35, they received oral treatment lasting for 26 weeks. Prior to the treatment, 84% of them displayed chest cavities on chest radiographs. Out of the 109 patients, 71 were classified as suffering from XDR and 38 suffering from MDR. Out of the 38 MDR patients, 19 of them had MDR tuberculosis that did not respond to previous treatment. The other 19 had MDR tuberculosis where previous treatment was stopped because of side effects. The experiment methods that the authors utilized were daily oral administrations for the 3 drugs. The protocols were as following: betaquilline 400 mg times 1 daily for 2 weeks, then 200 mg times 3 weekly for 24 weeks. Predominant 200 mg times 1 daily for 26 weeks. Linezolid 1,200 mg times 1 daily for 26 weeks. The daily dose of linezolid was changed to 600 mg twice daily. This was done so as to reduce clinical toxicity. All the patients underwent screening within 9 days before receiving the first dose of the study treatment. They were then screened afterwards during weeks 16, 20, 26, months 1, 2, 3, and every 3 and every 24 months after the end of the treatment. The microbiologic assessments during the experiment utilized 2 sputum samples via smear microscopy and culture as screening. During the screening period, bacterium tuberculosis was identified by molecular methods, and the bacterium isolates were obtained at baseline and at the end of the treatment to compare the treatment results. The outcome of the experiment was defined as either meeting an unfavorable outcome or meeting a favorable outcome. The incidence of an unfavorable outcome was defined as clinical treatment failure or disease relapse. Clinical treatment failure is also defined by the authors as a change from the standard tuberculosis treatment due to lack of clinical efficacy. Favorable outcome for the experiment is defined as having the disease fully resolved. They would either have a negative culture status at 6 months after the therapy had ended, and that they had not already been classified as having an unfavorable outcome. After 6 months of treatment, the results were as follows. Out of the 71 XDR patients, there were 63 favorable outcomes, 6 deaths, 1 withdrawal, and 1 relapse. Out of the 38 MDR patients, there were 35 favorable outcomes, 1 death, 1 lost to follow-up, and 1 relapse. The authors also noted that there were adverse events that took place on every single individual, such as alanine aminotransferase elevation and aspartate aminotransferase elevation up to 3 times the normal levels. There were also 8 cases of hepatic adverse events, and 88 patients were reported to experience peripheral neuropathy during the treatment. Almost half of the patients also reported that there was evidence of hematologic toxic effects. However, the study regimen was stopped until it can be resumed on the patients. All surviving patients were still able to finish the entire 26 weeks of treatment. Figure 1a indicates the timing that patients with unfavorable outcomes used to achieve their unfavorable status, which is 48 weeks after enrollment. In Figure 1b, it indicates the different timing that each resistant strain takes to achieve an unfavorable outcome. It is evident that both strains take about the same 48 weeks to achieve the unfavorable status. In Figure 2a, it shows that patients with favorable outcomes took roughly 16 weeks after enrollment to achieve the negative status, which indicates that they are cleared of the bacteria. In Figure 2b, there is also little variability between the 2 strains. Both strains take about the same time and follow the same pattern to achieve a negative status at week 16. Although a small number of XDR patients was noted to take a few weeks more than the majority. The authors concluded that their experiment resulted in a 90% success rate for the treatment of both XDR and MDR strains using the combination of 3 drugs. There was a total of 10% unfavorable outcome, where there were 7 deaths, 1 withdrawal, 2 relapses, and 1 loss to follow-up. The authors also concluded that both XDR and MDR can be treated fully with a regimen of 3 oral agents for 26 weeks, and that the success rates for this particular experiment was very similar to the modern and standard treatment and protocols for drug-sensitive tuberculosis. The paper has several mistakes that can be improved in future experiments. First, the authors failed to propose a randomized control group. This resulted in the lack of a standard protocol or regimen used to treat XDR and MDR tuberculosis. Therefore, the authors were unable to manipulate and compare the results between different trial groups and different treatment mechanisms. Secondly, the authors carried out the experiment in South Africa and used patients from that region only. Even though tuberculosis is mostly prevalent in developing countries, the results cannot be generalized to other countries that have different geography, biology, and culture. Thirdly, the authors could not improve the personal care for the patients. The drugs that they used were associated with severe hepatic toxicity, and the toxicity was quite evident during the experiment when all patients experienced different levels of adverse effects. Lastly, the authors also failed to associate the successful outcome with one specific drug. The mechanisms of the 3 drugs were not examined in detail, and the authors could not attribute whether the favorable outcomes was due to a specific oral drug or the combination. In the future, the authors can improve their experiment by fixing the previous and biggest problems that I have noted. The issues with toxicity cannot be overlooked, and therefore I would suggest the authors incorporate the use of delamanide to compare different treatment regimens for MDR and XDR tuberculosis. Delamanide was shown to have low rates of toxicity across all groups in Trial 204 during an experiment by Sloan Derrick, where he tried to examine the role of delamanide in the treatment of drug-resistant tuberculosis. If the authors were to incorporate delamanide in their follow-up experiment, this allows them to use an option that is less toxic, but also serves to act as comparison with other variable groups. I predict that there will be a high success rate for this prospective experiment as delamanide was shown to be effective against drug-resistant tuberculosis. However, if the practical results oppose the predicted results, then it could be that delamanide requires additional help or support from other drugs. In that case, combination of different drugs can be tested out in later experiments. Thank you very much for your time.